cardiomyopathy. We have the hypertrophic.
Doctor, sorry to take you back. Just restart answering the question. We just have the record so that we'll get all the stuff you're moving. You don't need to read the question. Just go and answer. Just straight to answering the question.
Okay, ma.
Thank you.
Okay, ma. Okay, so the question says, what is the diagnosis? What is the pathophysiology of the heart failure? How will you manage this patient, and what is the prognosis of the diagnosis? So from the history, I assume the patient has what we refer to as takotsubo cardiomyopathy. It's also known as stress cardiomyopathy or broken heart syndrome. It's one of the cardiomyopathies which we have. Just like a reminder, the cardiomyopathies include the hypertrophic cardiomyopathy, the restrictive cardiomyopathy, the dilated cardiomyopathy. Then we also have takotsubo, arrhythmogenic right ventricular dysplasia, and then left ventricular impaction. Then some new criteria have kept PPMC, that's postpartum cardiomyopathy on its peripartum cardiomyopathy on its own. So these are the different cardiomyopathy, and it said that these patients that have this takotsubo is usually as a result of stress. That's why it's also called stress cardiomyopathy or broken heart syndrome. So that's for option A. Option B says, what is the pathophysiology of this condition? So in these patients that have this stressful condition, they usually have a normal myocardium in like approximately about 90% of them. But during this period where they have this stress, it's been noticed that there's some form of suppression, like they have excessive secretions of catecholamines, methamphetamines, and I think phenylephrine too has been implicated. And then these catecholamines are the ones that lead to the transient ballooning of the apical portion of the left ventricle, because that's the area that has the highest concentration of the sympathetic innervation. So once there is a surge in the catecholamines as a result of distress, it can lead to that area being ballooned out. There is the one theory for takotsubo cardiomyopathy that says there is increase in like coronary spasticity, and then they may have transient spastic obliteration of like the coronary arteries, and then critical ischemia can also occur. So basically it's as a result of that increased production of the catecholamines that go to that apical part that has more of sympathetic innervation, leading to the ballooning out of that part. Then sometimes they don't really have an exact etiology, but this is what has been said about it. They also said that some of them, they might have something that looks like coronary artery spasm. You may have impaired cardiac microvascular function around that time. And some of the risk factors are maybe you have a bad news, or you learned of the death of someone, or anything that just leads to a surge in your catecholamines. Sometimes if someone has seizures too, it might also trigger that. But this patient, with all he had, including a cardiac arrest and everything, might have led to that surge in catecholamines that resulted in the ballooning of that part of the heart. I think that's the much I can remember about that. Then how will you manage the patient? And then what is the prognosis? Okay, generally for management of this patient, it depends on what the patient is presenting with. Like for this patient that has all of this, like what is being read. The management generally for this patient would include, it can be an outpatient care, it can be an inpatient care, depending on what the patient has. Some patients with takotsubo may have symptoms that look like acute coronary syndrome, and you would manage along that lines. But for inpatient, generally, it's usually supportive treatment. We can make use of beta blockers, which have been shown to be helpful in the patient. We can also, depending actually on what that patient has, but patients who have left ventricular will also do an echo. So if the patient has thrombus in the left ventricle, we'll need, the left atrium or the left ventricle, we may need to anticoagulate the patient. So generally, it is like supportive treatment. If the patient has like an overload, like the edema and all of that, we treat along those lines just to improve the patient. For example, in this patient, I just want to go back to the question. He has, in this patient, they said BP was 80/60, 8 units of blood. And then we can see that he has bilateral leg swelling or topnia. So we're basically going to treat the heart failure. So in seeing the patient, if the patient is still in hypotension, we can as well use inotropes to improve the patient's blood pressure. And then we can also make use of diuretics for our patient concerning the bilateral leg swelling. He may benefit from diuretics. Generally, we use the heart failure regimen if the patient has these symptoms. So we want to reduce the preload by use of diuretics. We want to improve patient's contractility by use of inotropes if there are no other contraindications. We want to reduce both the preload and afterload also, which we can use the ACIs and ARVs depending on if the patient is indicated for the patient and if there are also no contraindications. We can also do other newer therapies like the use of ANI for a patient, depending on if they meet the criteria, and then the use of SGLT2. So depending on, actually it depends on what the patient is presenting with. This patient looks like the patient basically is presenting with features of heart failure. The BNP is elevated, the patient has bilateral leg swelling or topnia, breathlessness. So it's looking like a congestive cardiac failure, and we'll definitely manage the patient in that line. So there's no like stamped out management. It's just supportive depending on what your patient is presenting with. And then so other things, if the patient is presenting with ACS features, we manage like ACS. And then if the patient is presenting like heart failure, we manage as heart failure. So it basically depends on what the patient is presenting with. In the process, if we have indications for anticoagulation in the patient, we also place our patient on anticoagulant. Then from the investigations we did, because arrhythmias are more common in our patients that have takotsubo cardiomyopathy. So if you do an ECG and you find arrhythmias, the patient may benefit from treatment of the arrhythmias, depending on if you what kind of tachyarrhythmias or bradyarrhythmias you have. You also treat in that line. Then in a very acute setting of takotsubo, the patient may need a permanent pacemaker, depending on if the patient meets the indication for pacemaker, then the patient can benefit from the pacemaker. It might be temporary, it might be permanent, depending on what the patient is presenting with. The same way the patient is presenting with ACS, you treat accordingly. If the patient needs PCI, you do. It's a supportive treatment depending on what the patient is presenting with. Then for the prognosis, I don't know if I can really remember the prognosis, but I think the prognosis for them it's good, because some of them have like a transient issue. So the prognosis can be good, but I'm not really sure of that. But I know that they have an excellent prognosis, but I don't know the percentage. Like, I can't really remember the percentage that was given. concerning the prognosis. But they can also have complications, but their prognosis is usually excellent. So that's all I can say. Thank you for listening. Please, someone can help out. Thank you.
Yeah, thank you very much. Thank you very much for a wonderful attempt. Dr. Success, you want to add something? You want to contribute?
Good morning, my teachers, senior colleagues and colleagues. Sorry, I didn't know my mic was mute when I was talking. Thank you, cardiologist Chineme. Sorry, I know I'm not supposed to talk because I'm not a cardiologist, but I just wanted to add that. Let me just start from where she ended. For patients with takotsubo cardiomyopathy, their prognosis is actually excellent. Most of them recover within 8 weeks. Okay, so that's why you can see that it's actually transient. And like she said, it may just be due to stress. Stress maybe from a loved one, maybe a girl's heart was broken or something from a breakup relationship. From us too, withdrawal from illicit drugs and even seizures too can also trigger takotsubo. So the death can actually occur in about 2 to 3% of patients, but generally prognosis is good. I agree that in the treatment, it's usually, symptomatic and what the patient has. And it also depends on the complications. Okay, so some of them, apart from the heart failure, they can also have cardiogenic shock, mitral regurgitation, ventricular arrhythmias, and also left ventricular thrombosis formation. Sometimes too, it can also lead to death in about 3% of patients. Thank you so much. That's what I just have to add from what I've said. Thank you, everyone.
Yeah, thank you, Dr. Success, for your contribution. Yes,
Dr. Atta, so that
yes,
we achieve a lot today. I want to just point out something so that the Dr. Chineme and the other participants will quickly answer the question. You guys seem to forget the part that this is not just pure takotsubo. This patient also has hepatitis C infection. This is a lot of comorbidities here. So your management, please talk about these comorbidities. How will you manage them? It's part of the management of the failure is nice and the rest. But remember, this is not just takotsubo, there are other comorbidities. So please, I want the participant, the Dr. Chineme, she did a wonderful talk on takotsubo, very beautiful. But I want her to, that's why we encourage participants to speak a lot in class so that you'll be trained on how to answer questions. Because the takotsubo is so beautiful, but what of the other things? That you might be surprised. Takotsubo might just be one third of the answer to the question, the answer to the question. So, but the examiners also want to hear about the hepatitis C. They also want to hear about the alpha-1 antitrypsin, other things too that they presented here. So let her just say it. It's a discussion. Let her say as much as she can say. Dr. Success, thank you so much for coming to other participants, those in gastro, those in cardiology. Please let's make it a rich discussion so that by 7:30 we'll move over to the second question. We want it to be as rich as possible so that we know that even though the presenters were not in class, those that were in class, it was a wonderful time for them. So thank you.
Okay, thank you, Ma. Okay, for this patient, it said a 52-year-old man with hepatitis C infection, alpha-1 antitrypsin deficiency, and liver cirrhosis. So he had already gotten to liver cirrhosis and he had had a liver transplant. It's after the liver transplant, he came down with cardiac arrest and the following. So I think for these patients, we have to do like post-transplant, we have to take care of that. Then I also see that the patient is asthmatic and obese. So for each of the symptoms, sorry, ma'am.
Let me just quickly add. The takotsubo is like the king and queen. Others are just things you just say. So don't dwell so much on them. Do you understand? Those are things, the exam there's no time in the exam. So you quickly say the major thing, then not briefly on all the others. Do you understand? So that's what I was wanting to put. You can continue, please.
Okay, so I'll start with the fact that the patient is obese. So we are going to look at lifestyle modification for this patient, look at weight loss programs, how we can help the patient to achieve at least fairly normal weight. for this patient. And then, of course, if the patient meets criteria for other interventions like surgical interventions, we can also do that. And for the asthmatic condition, of course, we are going to do use the peak flow to find then which his asthmatic condition, of course, with the use of our ICA inhalational steroids, and also depending on whatever the patient needs based on that classification. When we use the general classification, whatever the patient needs, the asthma will be properly controlled. Then for the post-liver transplantation, of course, we'll counsel our patient or what happened to him after the transplant. Look out for post-transplant infections, complications for him, including both infections and all of that. And then, of course, our immunosuppressants, if the patient needs it. And thank you for these contributions.
Dr. Atta, some people's hands are raised. Dr. Rukaya, you can go ahead, please.
Dr. Rukaya or Dr. Chidima, any of you can.
Okay, good morning, my teachers and colleagues. I just want to speak about I wanted to make some clarifications and also speak about the fact that the patient had a blood pressure of 80/60 and also had a cardiac arrest too. So the possibility that this patient might develop acute kidney injury is quite likely. And so the essence of trying to monitor his serum electrolyte, urea and creatinine with the urine output is also important. Then I wanted to ask too that with this kind of cardiomyopathy, do they present immediately with symptoms of heart failure? Since it's something that's happened acutely, would they present with leg swelling and all those things immediately? Or I'm just wondering, can there be another cause of the bilateral leg swelling? That's just a question. And then for the alpha-1 antitrypsin deficiency, is there the possibility that, he was misdiagnosed, maybe he has more of, I don't know, COPD rather than, I don't know. I'm not sure that maybe I should start that. Thank you.
Yeah, thank you, Dr. Chidima.
Okay, sorry.
Hello?
Let me try to say something about factor for liver cirrhosis. So the patient has alpha-1 antitrypsin deficiency, hepatitis C, and liver cirrhosis. So I think the alpha-1 antitrypsin there points more to the liver cirrhosis there in the context of the question. Then it was already told to us that the patient came down with features of heart failure after the whole resuscitation, and they had 8 units of PAC cells of transfusion and cardiac arrest, that thereafter the patient came down with breathlessness, autopnea, and bilateral leg swelling. So that was why heart failure, we're managing that. That's why we felt it was heart failure and went for that management. I don't know, that's my contribution. Thank you.
Okay.
Okay. Yes.
Okay. Good morning, our facilitators and participants. Sorry, my voice is a bit groggy, so we'll manage. I would like to make a few contributions, just to chip in some of the gaps. So although takotsubo called stress-induced cardiomyopathy typically happens when there's some acute stressor or negative event, including loss of a relative, loss of job, something like that. It can also occur due to extremely positive events. So somebody wins the lottery, gets that job they've been wanting. So it's not only negative events, it can occur as in the setting of a positive event. That's one. Secondly, physical stressors like a new diagnosis, going for transplant, are also triggers. And to look at the prognosis of this patient, although in general, takotsubo has excellent prognosis, most patients would recover, the ballooning of the apex would recover and all of that, there are some poor prognostic factors which were listed, a lot of them, in this patient's case scenario. So let's start with the gender. Male patients tend to have worse prognosis than females, although it's more common in elderly females. Male patients has worse prognosis, so that's one. Presence of asthma or COPD also confers bad prognosis. Physical stressors. So this patient had mainly physical stressors. He has many comorbidities. He had hepatitis C. He had transplant and all of that. So these are physical stressors. So that's another poor prognostic factor. He had severe anemia, requiring 8 pints of blood transfused. Anemia is a poor prognostic factor. Then presence of cardiac arrest. For patients that have cardiac arrest, their prognosis drops. And cardiogenic shock. So he had both. He had cardiac arrest when he was resuscitated. He was in shock. BP was 80, 60. So this patient has a barrage of poor prognostic factors. So I think for that question, although one would say that prognosis in general, it's good, most patients recover, blah, blah, blah. However, this particular patient has quite a number of poor prognostic factors, including all of these that we've listed out. So his prognosis may not be that great. In addition, for their management, this patient was in shock. Now, in the pathophysiology, catecholamine surge and damage due to catecholamines is one of the main pathophysiologic mechanisms for the ballooning of the apex and the akinesia and whatnot. Now, when managing their cardiogenic shock, typically we know we use inotropes, many of which have some sympathetic activity or components. So in them, although inotropes like dopamine, dobutamine, whatever, noradrenaline could be used, as much as possible, if there is room, if the facility has mechanical circulatory support, that would be preferred to giving things like noradrenaline and all of them, because that is also increasing catecholamine levels, which might cause further damage to the myocardium. Okay. Lastly, I wanted to say, what was that? Yeah, so these are basically, so the presentation, this patient presented with heart failure, cardiac arrest, cardiogenic shock. Sometimes they may not present in heart failure. They can come with sudden chest pain, diaphoresis, and all of that looks like an acute coronary syndrome. And that is the number one differential of it, an acute coronary syndrome. We see mild elevations on troponin, ST2 wave changes, but when they go for coronary angio, they'd have non-obstructive coronary arteries. So it is a differential for MI with non-obstructive coronary arteries, the so-called MINOCA. So that's the typical presentation, the acute chest pain, but a percentage of them present with heart failure, a percentage with some arrhythmia, some with cardiac arrest, and some with shock, like we've seen, and then some with thrombus. So I think these are my contributions. Thank you. But some of the risk factors as well, apart from the psychological stress and whatever, patients with asthma, COPD, diabetes, background, anxiety, depression, or schizophrenia are all risk factors that make one more likely to develop takotsubo when they have that acute life event or acute stressor. Thank you very much.
Okay, thank you, Dr. Rupert, for an elaborate contribution. Thank you so much. Any other contribution? Because we are way past 7:30. Okay, let me read some of the comments from the...
Dr. Fatima, also, okay, read the comment. Let Dr. Fatima just say one or two things, then move over to the next question.
Okay, Dr. Olalekan said another name for the takotsubo cardiomyopathy is apical ballooning syndrome. Dr. Sawa said the reported mortality among patients with takotsubo cardiomyopathy ranges from 0 to 8%, with a mortality of 4.1%. Then Dr. Christie like B said, prognosis is usually very good at almost perfect recovery. This is observed in 96% of cases within 4 to 8 weeks. Dr. Shamsuddin said patients should be managed in the cardiac position, may also benefit from oxygen therapy, some basic investigations like renal function tests to look out for complication. Then Dr. Emmanuel said HCV can predispose to left ventricular aneurysm. So those are the few comments in the chat box. So Dr. Fatima.
All right. Thank you very much, Dr. Chidima, for the excellent attempt, and thanks all participants for contributing. Just to add to all that, I think if we're asked to manage this patient, it's important to see that management entails brief history, examination, investigation, then treatment, and ideally this patient should be managed in the ICU. Then followed by ABC of resuscitation is very important. Then consider supplemental oxygen, and continuous cardiac monitoring is also important. And looking at the scenario, this patient has asthma, so you can't give beta blockers. Management involves giving treatment for heart failure as well as the takotsubo, which is managed just as in the case of acute coronary syndrome. So we can consider giving antiplatelets like aspirin, clopidogrel, and as well as anticoagulation with heparin or low molecular weight or high molecular weight, depending on which is available. But we must remember that the BP is low, so we cannot give drugs like beta blockers, ACIs, or ARBs or nitrates that we usually consider in the management of heart failure. And then bedside echocardiography is also very, very important, because this patient, as he presented with symptoms like ACS, so when you do bedside echo, it can show you the apical ballooning. So that can help identify it easily. However, coronary angiography is the most important, because it will show non-obstructive coronary arteries. Then with regards to the pathophysiology, the heart failure in these patients is majorly from the LV systolic dysfunction. As we know, the apex is hypokinetic or even akinetic. So there's loss of systolic function at that site. And as a compensatory mechanism in them, there is obstruction at the left ventricular outflow tract. So this obstruction can also reduce cardiac output. So together with LV systolic dysfunction and left ventricular outflow tract obstruction, hence they have symptoms of heart failure. So this is my addition. Thank you.
Okay, thank you, Dr. Fatima, for wonderful contribution. Any other contribution from our teachers before we move to the next? Any other contributions?
Dr. Atta, please, you can. Okay, Dr. Remigus, please go ahead.
No, I think we should just move ahead. Chief is not around. That would have given us a big lecture. So let's just go ahead.
So do we still go ahead with the West Africa, or we'll go to the national?
West Africa.
Okay, please, can we check what is the next? Okay, let me check the next questions that have not been answered. So we'll go to question 3. Okay. Okay, question 3. So this is okay, this is a neurology. It's a neurology question. Do you have a neurologist in the house that will help us?
If you don't mind, I can answer. I don't know if I've talked
all right,
too much.
Okay, Dr. Success.
Okay. Good morning, my teachers, senior colleagues and colleagues. So for question
3A.
Okay, for question 3A of the W, for the practice questions, it reads, an 18-year-old female undergraduate is brought into the emergency room by relatives convulsing. After 5 minutes, she's still convulsing. The same questions are: A, what is status epilepticus? B, list 5 causes. C, how will you investigate? D, outline your management for this patient. And E, list 3 complications of status epilepticus. Now, usually status epilepticus is an acute life-threatening neurological condition that occurs when there's actually failure in the mechanisms that should terminate seizures. Now, usually when seizures occur, they terminate spontaneously. But when there's status epilepticus, there's failure of these seizures to terminate, thus leading to abnormally prolonged seizures. Next is list 5 causes. So the causes may include metabolic conditions like hypoglycemia, hyponatremia, hyponatremia. It could be due to another differential, maybe dizziness, transient global amnesia, even our sister psychiatric conditions like dissociative states, hyperventilation, malingering, and also psychogenic seizures. How will we investigate these patients? Now, for this patient, we may request for a brain MRI to show if there's any focus, any epileptic focus, maybe from tumor or maybe from infections. We could also do, very importantly, we'll do an EEG to actually know, where the seizure is coming from, the pattern, the location, and so on. This girl is 18 years. And so we might need to do a urine toxicology. And, she's 18 years and she's also an undergraduate. Many a times we see, students abusing, illicit drugs. So we might want to do that to also elicit if she is also on any illegal substance, so help us, to manage her effectively, especially to rehabilitate her. Other investigations we may want to do include serum electrolyte and creatinine, random blood glucose, which is very important, okay, to check if it's, of course, from hypoglycemia too, and also, of course, she has been seizuring for a long time. We also want to know which can deplete, the glucose level. So we want to also know that, because that will also help us in our treatment to also give dextrose. But also other investigation we might want to do to rule out, the cause or possible cause causes include liver function tests, and also we want to do a chest X-ray, paraventure should aspirated, and also want to do maybe culture, blood culture and urine culture. Now, the other question says, outline your management for these patients. Now, for the principles of management for these patients, the first one will be ABCD of resuscitation. Okay, I want to identify and treat comorbidities as much as possible to terminate the seizures as soon as possible. And of course, this patient should be nursed in an IC, intensive care unit. And then also I want to rehabilitate this patient. Now for the complications from status epilepticus. Okay, so this patient has been seizuring and so for a long time. And so she may be at risk of, super refractory seizures. She may have, of course, from rhabdomyolysis, she may have acute kidney injury. She may also have cardiac arrhythmias, okay, from the surge of catecholamines too, and of course, respiratory failure, either from hypoventilation or from aspiration pneumonia. This patient too may also have sepsis. So these are the complications. Of course, for a patient that is seizuring, she may also have injuries, head injuries, facial injuries, dislocation of the shoulder, and so on. So that's That's for the STEM. If you don't mind, I just wanted to add something else. Okay, so usually, like I said, status epilepticus occurs when there's failure of mechanism to terminate seizures. Now, according to the International League Against Epilepsy, there's the classification of status epilepticus was done in 4 axes. Okay, so the first axis was semiology, the second was etiology, the third ECG pattern, and of course the fourth age. Now, for the semiology, we want to know, the semiology of the symptoms that this patient is having. Is this patient having a prominent motor symptom, status epilepticus, or this patient is without prominent motor symptoms? Why is this important? We know that not all patients that have status epilepticus that convulse. What do I mean by that? So not all of them may have motor manifestations. And so when there's motor manifestations of seizures, it is known as convulsion. So we could actually have convulsive status epilepticus. Okay, that could be myoclonus, focal, and which will consist of the epilepticus facialis continua. Okay, and even Jacksonian march. Now, we could also have, the focal, non-motor symptoms, okay, like the absence. Then for the, based on etiology, the axis based on etiology, usually I prefer using the acronym VINDICATE, V for vascular, I for infectious, this patient have meningitis, encephalitis, N for neoplasm. So are we dealing with an SOL causing these seizures? Okay, so D for, like drugs or neurodeterminating or degenerative conditions, drugs intoxication, eye intoxication, and then C, we could have connective autoimmune conditions causing these seizures, like cerebral lupus. Then it could also be trauma, due to trauma, okay, and of course, metabolic causes too, okay, like uremic encephalopathy and so on, electrolyte derangement too. Now, it could also be from epilepsy syndromes, okay? Epilepsy syndromes like Landos-Gossett syndrome, okay, the juvenile myoclonic epilepsy, like Lovera syndrome, and also Dravet syndrome. So these are epilepsy syndromes. So you want to also find out, is this status epilepticus coming from an epilepsy syndrome? Okay. Then another axis is that of ECG findings rather. Okay, so you want to know the pattern. You also want to know the location. So are we dealing with lateralized epileptic discharges, or we are dealing with generalized, so that will also help us to classify, status epilepticus. Then also the age, seizures that occur in neonates are different from the ones that occur, in adolescents or in adults, okay? Like in adults, the most common cause of seizure in adults, especially more than 50 years, is stroke. So post-stroke seizures are the most commonest. Now, for patients that are less than 50, most of the time, they say in Africa, they say it's due to neurocysticercosis. So for neonates, for infants, so it's important that we know their age so that we can also categorize them accordingly. For the adolescents, are they having juvenile myoclonic epilepsies? Okay, so these are how we actually classify, status epilepticus, according to the International League Against Epilepsy. Maybe I will take more questions. If it's epilepsy, I will talk to you tomorrow. Thank you so much. But before I end, I want to say that there's an International League Against Epilepsy. And please, we want everybody to join that league so that we can actually kick epilepsy out of Africa. Thank you.
All right. Thank you, Dr. Success, for a wonderful attempt. Dr. Ikechukwu, your hand is raised so you can make your contribution.
Thank you. Good morning. My chiefs and
Yeah, good morning.
colleagues. I just want to add to what Dr. Success has said already. So in status epilepticus, as she said, is actually due to failure of mechanisms that terminate seizures and the persistence of the ones that initiate seizures. But then there is a time point to it. So you have the first time point, which is 5 minutes, and the second time point, which is 30 minutes. In the first time point, it means that when seizures start, they usually terminate in 5 minutes. So when you have seizures that are ongoing after 5 minutes, that means the likelihood of that seizure to terminate is low. And that's where you will need to start your treatment for the seizures in consideration to status epilepticus. And the second time point of 30 minutes is that when a seizure lasts till 30 minutes, it means that there is likelihood of neuronal injury. That's why before now, status epilepticus was defined as seizures that are persistent for 30 minutes without return of consciousness, or seizures that occur without return of consciousness or baseline in between the episodes. So, but they, with recent research, it's now shown that after 30 minutes, seizures are likely not to terminate on their own. And then when it persists till 30 minutes, the likelihood of causing neuronal injury is high. So that's where you start initiating your management plan. And then in managing these patients, she has listed the investigations you do. Ideally, in confirming status epilepticus, you need the EEG. You can have the semiology with you. The semiology will actually tell you whether it's convulsive. But if you have a patient that has altered sensorium, you want to do your EEG also to rule out non-convulsive status. And then you also need to investigate for any other etiology that may be causing it, as she listed. It might be infectious, inflammatory, autoimmune, metabolic, all in that line. So when you've investigated this patient and you've confirmed and these seizures have not terminated after 5 minutes, you want to initiate your management plan. And in this management plan, you go through your ABCD of resuscitation, make sure that you check your electrolytes, correct your glucose if it's abnormal. But then for the status epilepticus proper, there is a guideline in the management, so you need to follow that guideline. So if the patient comes, if the patient presents to you in the hospital, if they've come through the community, there are options of giving buccal-midazolam and diazepam. But when they come into the hospital, you need to start them on benzodiazepines, because the more the electric, irrespective of the consciousness, irrespective of the conscious level, because the more the seizures are ongoing, the more the risk of neuronal injury, and you need to abort these seizures. If they come into the hospital, so you can start with lorazepam. It's usually given as 4 milligrams of lorazepam IV, and then after 5 minutes, if the seizures are still ongoing, you will have to repeat the lorazepam. So you have the second line that you use, especially when the seizure is ongoing between 15 to 20 minutes. You want to use either of the second line medications that you have in your arsenal. So these can include the phenytoin, levetiracetam, and sodium valproate. So in the established status epilepticus trial, it showed that you can use either of them, but then you want to know, also consider the side effect profile of these medications that you're giving. And then the rates of infusion of these medications. So for phenytoin, the side effect profile is a bit high, and you need to give it under cardiac monitoring. And then it also, you infuse it over a longer period of time, I think 20 to 30 minutes. For levetiracetam, the side effect profile is a bit lower, and you can infuse it over 5 minutes, as well as 5 to 10 minutes, as well as with sodium valproate. So most people tend to go with levetiracetam, and levetiracetam is actually a broad, a kind of a broad anti-seizure medication that covers both focal and generalized seizures. So it's better to attend towards generalized seizures. And then the dose of this medication, you can actually code it with 60, 40, 20 per kg. So for levetiracetam, you can use 60 milligrams per kg. For sodium valproate, you can use 40 milligrams per kg. And for for phenytoin, you can use 20 milligrams per kg. Where phosphoenolitoin is available, you can also consider using that one. So, but then you need to adjust these medications according to the renal function. So there's always if the renal status is affected, you need to adjust these medications according to the renal function, so you don't worsen the side effects that might come into this medication. Most of the time, you can see that these seizures get terminated when you institute this management outline. But then when it's not terminated and you've given the first dose of these anti-seizure medications, you have to wait for another 20 minutes to check, 15 to 20 minutes to check if there is any response. If there is no response, you can repeat the loading dose of this medication. However, if there is a response, you can continue the maintenance dose. When you've given the loading dose of these medications the second time, you can then, and the patient is not responding, you have to call the ICU. Ideally, the ICU looks at the functional level of the patient and the functional kind of score of the patient to see if they will be admitted into the ICU. So if they are, they might have to take over the respiration and then sedate these patients to avoid further seizures ongoing. In addition to the complications that she listed, because these seizures are persistent and it's been ongoing for a long time, these patients are actually liable to get neuronal injuries, and this can cause persistent neuronal deficit. And also, in addition, we also need to remember that this can also be increase the risk of SUDEP, that is epilepsy. So we just need to be careful when we are managing this patient. And more importantly, we need to assess for the risk factors or the cause of this condition as she has already outlined and manage them appropriately. Thank you.
Okay, thank you, Dr. Ikechukwu, for an elaborate contribution. Any other contribution before I get to the chat box?
It's 7:55, so go
Okay,
to
sorry,
the chat box.
7:55.
Yes.
Dr. Tanimo is raising his hand.
Okay, okay. So,
thank you very
Dr.
much
Tanimo,
for those and our teachers. I am just regarding for the exam, because there are some salient words that in the exam, if it's asked, you have to say them. If you don't say them, then you may fail the question. When they say define status epilepticus, so that 5 minutes should be in part of the definition. The seizure lasts more than 5 minutes. But if you keep on moving front and back without saying the salient word that they want, the person may lose the person may lose that question. So that is it. And also for the status epilepticus, you have to also, for the management of status epilepticus, you have to also look for what? For calorie, for the energy when you are managing, because they tend to lose much of they need energy for that convulsive episode. It requires energy, so that calorie supplement and other part of it should also be included in the management. Thank you very much.
Thank you, Dr. Tanimo, for the contribution. Okay, I think in the chat box, Dr. Dotun drops the recommended. Can you drop it, please, in the WhatsApp group? Drop the
He has
picture.
done that already.
Okay. So you see, he wants to reiterate the causes. The common things are metabolic disorders, hypoglycemia, hyperglycemia, hyponatremia, CNS infection, and meningitis, vascular disorders, stroke, and rare causes that may be considered new onset refractory status epilepticus and withdrawal of psychoactive substance. And then Dr. Steele said the definition, there are two major things: time criteria, now 5 minutes to allow for early intervention, consciousness, no regain of consciousness between episodes of seizures. Okay. Dr. Chiamaka said autoimmune encephalitis is more likely in this age and in this age and sex than drugs. Okay. I think that's that we have in the chat box. Okay, so I think is there any contribution before we hand over to our teachers to close the class?
Is there any last contributions? I will end the class by 8 or a few minutes past 8. Also far, I think Dr. Ikechukwu, Dr. Success gave us an inaugural lecture on status. They both did a contribution from both, really. It was quite lucid. There was so much stuff. So I think I'll advise every participant to go back and listen to this, watch this video later. They release a lot of stuff there on status. So please watch it again today so that it will be really fresh. Because as I'm saying it's like overload of information. You feel you heard everything. But when you listen to it again, you realize you didn't hear a lot. So I must appreciate the first speaker, Dr. Chineme. Thank you so much. Thank you. And all the people, Dr. Rukaya and others that came into and make the discussion more elaborate and interesting. Thank you so much. I appreciate the success. Thank you, Dr. Ikechukwu, Dr. Sani, Dr. Dotu. Thank you. I don't know if I got all the names, but if I didn't mention your name, it doesn't mean we don't appreciate you. We do. Thank you so much for making an unfortunate situation quite an interesting one, turning it around this morning. Thank you so much. I think we just hear from our Chief Chitu. Dr. Kopi, are you in class? I think just hear from them and quickly close the class. Dr. Kopi, you hello? First, then Chief Chitu just round up. Hello, Chief. Good, sir.
Yeah, let me just chip this in, please.
Okay.
Yes. From what we said earlier, it's obvious that we're going to have to remove some
Chief,
from the class.
Do I need to? Let me stop recording.
Oh, yeah.